So welcome. I'm Dr. Russell Cohen. I'm a professor of medicine and clinical director of the Inflammatory Bowel Disease Center at the University of Chicago in Chicago, Illinois. And this is a podcast from the GI Health Foundation's GI ReConnect 5th conference this year in Denver, Colorado. Along with me today is one of my guest faculty, Dr. Parambir Dulai from Northwestern University. Parambir, why don't you introduce yourself?
Yeah, I'm Parambir Dulai. I'm at Northwestern University, also in Chicago, Illinois. I am Associate Professor of Medicine and Director for Precision Medicine for the GI Division.
Terrific. Well, thanks, Parambir. So, we had a really great discussion group yesterday at the summit where we looked at many different topics that are really hot topics for inflammatory bowel disease. And today you actually gave an outstanding lecture that raised additional questions as to what are our real targets and what are we really looking at for the disease and how will that change. I want to concentrate first on just a general concept. We have this pipeline of therapies that are coming in all directions, which is very, very exciting because we haven't had this for a while. And in some ways, we can break them down into different families of therapies. And I was wondering if you could maybe provide just a little insight into these major families and what your thoughts are as to the potential for them being breakthrough therapies in inflammatory bowel disease.
Absolutely. So our oldest family of drugs is the anti-cytokine therapies. So this dates back to the case reports where they found elevated TNF-alpha in Crohn's patients and then repurposed infliximab for the management of Crohn's and IBD. And since then, we've had a tremendous growth in our understanding of the cytokines that are relevant for driving inflammation. So we've had a growth in not only the anti-TNF therapies, but also the anti-interleukin-23 therapies, as well as newer agents that are coming to market that target a sort of new mechanism known as TL1A. And those anti-TL1A therapies, I think, are a new addition to this cytokine family that have a tremendous amount of opportunity. And so then the other class that came to market was anti-trafficking. And so we know once the inflammation starts in the GI system, it creates this homing mechanism for the immune cells to know where they need to go to be able to help resolve and deal with that inflammation. That homing or trafficking was the next big target. And we've had anti-integrin therapies that block the adhesion of these cells to the vasculature. And then we actually have also other anti-trafficking or anti-lymphocyte therapies that block their integration or sort of trafficking through the lymph nodes, such as the S1P class. Following that, we've had a newer sort of revelation probably in the last 5 years for what are called JAK and TYK2, Janase kinase and TYK2 inhibitors. And they target specific cellular mechanisms that promote upstream inflammation of a lot of these pathways. We've had a few JAK inhibitors now come to market, and we're seeing some potential promise with some of the TYK2s in the space as well. And then we have a huge growth in what I would consider or bucket as other therapies, which have sort of unique one-off targeted modulation of various things from neutrophil modulation to specific pathways and even potentially even the microbiome at some point.
Well, that's a really fantastic review. One area, at least that's been developed therapeutically in ulcerative colitis, has been the S1P modulators. What's your understanding as how they work?
Yeah, so S1P modulators are a form of anti-trafficking. So lymphocytes use lymph nodes in different pathways to be able to understand how they need to get to the area where they're going to sort of help resolve or deal with inflammation. It's like bait for a shark, right? It sort of follows the trail to figure out where it's going. And S1P modulators will essentially remove that trail and cause those lymphocytes to essentially get lost in the lymphatic system and not get to that target area where they were promoting inflammation in ulcerative colitis. And I think that was a really unique, novel mechanism that just came to market in the last few years and has had some efficacy as we start to use it in practice.
When we had our discussion, I pushed all the experts to say what would be the next best thing. And very few actually answered me directly. But many of them, and perhaps me included, are very enthusiastic about the idea of combining advanced therapies. What are your thoughts on that?
Yeah, we've seen a therapeutic ceiling when it comes to all of our therapies. I just commented on the tremendous growth in different mechanisms and even within the mechanisms, multiple drugs. But despite that, we've plateaued at maybe 30 to 40%, effectiveness in some of the clinical trial data. And so if we're really going to break that threshold of only about a third of patients actually benefit from each individual drug, the thought has emerged that whether we could combine two mechanisms together. And that originated from some translational data that suggested that maybe combining an IL-23 inhibitor with a TNF inhibitor may actually capture more population than each of them alone. Then it brought up questions around, can you identify mechanisms of non-response for one drug that you could use combination therapy for, such as a JAK inhibitor with an anti-integrin to try to optimize that early response and then maintain them on something else. And so a lot of the combination therapy trial data is showing that you get an incremental benefit in efficacy. And we're now starting to see questions emerging around what's the right combination and how do you personalize that to individual patients, and then co-formulation of those drugs for ease of administration.
So let's say you were going to design a combination. What would be your game plan? Would it be based on the different therapeutic angles at which they come in? Would it be based on safety? Would it be based on a combination of things?
Yeah. So in an ideal world, you would have figured out what the mechanism of non-response is for two separate drugs and then saw that you were able to overcome each of them with the combination of the two. That's, not where we are right now. Where we are right now with combination therapy is, can we think about combinations that are safe and implementable? And so oftentimes we'll use a backbone drug, as we'll call it, as a safe and sort of durable treatment option, and then a secondary add-on that has a little bit more potent sort of suppression of certain pathways to help augment that response, and then think about peeling off the more potent one and keeping the one that has a little bit more of an established safety as the backbone over time.
And then potentially being able to reintroduce that second therapy on, quote, flares, maybe like we're doing for many years with steroids, where someone is steroids when they're sick, we get them on a non-steroid therapy for a while, they have a flare for whatever reason it may be, we re-add back on perhaps that more acute agent, if you will, puts out the fire, and then go from there. Is that kind of what you're thinking?
Yeah, and that's only been feasible now because of the transition into the small molecule space. So a lot of our therapies were biologics, right? So large molecules, you had to worry about anti-drug antibodies. If you stopped them and tried to reintroduce them, they may not work as well. But with the transition towards small molecules, particularly with JAK inhibitors, TYK2s, and some of the other microRNA stabilizers that are coming to market, you can think about episodic use. And we've been doing episodic treatment with prednisone all the time to bridge people through until the biologic takes effect. But now thinking about using a small molecule advanced therapy for that episodic use to bridge them is becoming a component of the discussion with combination strategies.
We always hear about the future is going to be, we're going to have some type of way of knowing what's the best therapy for each patient, tailoring the therapy to them, using some type of marker in their stool, their saliva, or their blood. I mean, are we there yet? Are we close? What do you think?
I think we are making, progressive strides, and you're seeing series of positive divergences towards that ultimate goal. And I think you're seeing those across a few different areas. First, we're beginning to recognize that we need to potentially reclassify inflammatory bowel disease into different subcategories based on their phenotype. And we're realizing those phenotypic or how they present variations do link to response to different treatments. I think the second thing we're learning is that when you resolve the amount of probability of response you can get from clinical features, you can add some molecular gene markers to further augment that and see how much more you can predict for treatment response. But the third most important is no matter how well you personalize it up front, there is a tremendous amount of post-treatment monitoring and optimization that's still available. And we have to think about ways to optimize our targets, how we treat to those targets, how we achieve those targets, and how to optimize the post-initiation maximum value we can get out of them.
You know, it's interesting because you gave a fantastic lecture at the beginning of today's session, at which point I threw you a question, as you may recall, whether we have patients whose diseases are changing during their course of therapy. And I gave an example of a patient perhaps on an anti-TNF where they had great results, doing well, and all of a sudden they stop doing well and they still have very good blood levels of that medicine. I mean, is this something that is explicable, and what do you think is happening?
Yeah, so David Rubin actually put it really well today when he said that our immune systems have immune redundancies because they're there to protect us. So they have to find ways to get around something that's blocking them so they can continue to protect us from what they think is an external threat. And so in a lot of our patients, we think these immune escape mechanisms or this immunological redundancy kicks up in response to something that they're sensing and probably drive some of that specific scenario where you had somebody who originally did well and the immune system for those 2 years has been trying to figure out how to get around it and finally figured it out, and you're starting to see the inflammation come back.
So some, like a patient who might have a cancer that we block one pathway, but the cells then find another way around.
Right. And if you make the analogy to oncology, you know, they learned that early on. And then they started actually giving treatment to push cells in a specific direction where they knew that the next direction would be targetable with 100% efficacy. And you started to see them do priming and sequencing to get the cancer cells to behave the way they wanted to so they could really get rid of them. And I think IBD eventually will make that transition as we learn more about these escape mechanisms.
You know, one of the areas that we discussed, although somewhat briefly at our roundtable, was the influence or the possibility that by adjusting the microbiome, that we may have a therapeutic intervention, either the microbiome directly or maybe through diet. I mean, that conversation somewhat petered out during our panel. What do you think is the real reason we were so excited with the fecal transplants and all these different therapies? Why hasn't this really panned out?
Yeah, I mean, so the fecal transplant data was really exciting, right? Because it was it really proof of concept that if you change the microbial composition and what it does, you can really actually resolve inflammation and maybe a bunch of other things. The problem was we realized you had to keep giving it, because there was very often an issue with the engraftment of the bacteria and they weren't staying there. So that sort of resulted in an uncertainty on how you could really target the microbiome in a long-term fashion to change that, permanently. As I said, there's a whole component that the immune system is always trying to respond, and there must be some stimuli for that. And we know the bacteria are often a very clear stimuli for those things. And so there is growing interest and efforts to look at targeting specific bacterial subsets, either through antibiotics, example of oral vancomycin in PSC patients who have colitis, bacterial phage therapy, these naturally occurring phages that are known to kill bacteria, and repurposing them for actually treating conditions, or targeted therapies that actually block the byproducts of those bacteria through protease inhibitors or some of these other inhibitors that can actually be delivered and used in a chronic fashion.
Do you envision, though, that we would be able to make these manipulations simply by prescribing a certain diet, either increasing something you're taking in or taking something out of the diet?
I think we can. I think we can. And the problem for why we haven't yet is we don't have great measurement tools. I don't know what I ate for lunch today. I know what I ate, but I don't know where it came from. I don't know what the content of it. I don't know what the micronutrient levels are. I don't know exactly what my diet is doing to my microbiome. And so until we can have that measurement tool to say, this lunch contains X% of all these different things, and that's going to influence your microbiome in this way, then we won't be able to intervene. But once those tools are developed, just like we have blood pressure cuffs for blood pressure, right? We've got hemoglobin A1C for diabetes. We now have endoscopy and histology for, IBD. Once we have dietary measurement tools that are quantitative and correlative, then we could actually sort of intervene on those and potentially about adding them as combinations to the biologics to deal with the antigenic stimuli that's causing that immune escape mechanism.
You actually provided me a very nice segue to our next major topic. You and I see patients with inflammatory bowel disease. We don't know who's coming through the door. But one of the things that we've found that there are certain comorbidities that are higher risk in inflammatory bowel disease and also may impact our therapeutic choices. Some of these surround the idea of inflammation. And of course, as you know, the leading cause of death for most people is cardiovascular disease. What are your thoughts on inflammation, cardiovascular disease, and are patients with IBD at higher risk of these things?
Yeah, there's a lot of literature and multiple large studies that have shown that the inflammatory process from inflammatory bowel disease increases your risk for blood clots, heart disease, stroke, and other chronic inflammatory vascular related conditions, right? And so there is an underlying relationship between the IBD and those chronic conditions. And so treating the IBD is extremely important. What we have to balance that against is that sometimes our therapies may have some association for risk in the cardiovascular space, right? So we tend to shy away from anti-TNF therapies in patients who have decompensated heart failure because of some older literature that it may worsen those components. There are some labeling warnings for JAK inhibitors related to cardiovascular or blood clot risks that offer us an opportunity to make sure we engage in a shared decision-making process so that we can personalize that and take those factors into consideration. So I think we need to treat the IBD, and then if they do already have those comorbidities, we have to take them into consideration when choosing the ideal treatment for individual patients.
So what you're saying, though, is, especially at the tail end of your comments, is treating the IBD, so treating the inflammation, getting the inflammation levels in the body down as low as to normal as we can, especially in a long lasting condition like IBD. I mean, we're meeting these patients as children, teenagers, early 20s. They have normal life expectancies. So a lifetime of inflammation can lead. We knew this years ago with bone density. We didn't realize that it translated to cardiovascular disease back in the day. But the idea that perhaps acting early may not just help decrease the obvious IBD, Crohn's, and colitis related outcomes, but may actually decrease the very important cardiovascular inflammatory outcomes in the body too.
Yeah, I completely agree. And that's why getting that inflammation under control is extremely important. And making sure you choose the therapy that's going to be most effective first, followed by a conversation on whether any of the safety considerations may modify that decision.
One of the other major areas that you had mentioned, moving a little away from cardiovascular disease, is metabolic diseases. And perhaps I shouldn't say moving away from cardiovascular, but at least for now, metabolic diseases, diabetes, these other major issues that are particularly affecting Western societies. What's your understanding of the role of inflammation in those conditions? Yeah,
so there's a huge shift in how we think about metabolic disorders and that they are actually inflammatory conditions. I mean, NAFLD or non-alcoholic fatty liver disease underwent a renaming into metabolic and sort of an inflammatory disease instead. Andres presented some amazing data today on the role of metabolic considerations in IBD and how treating those might actually be beneficial. We don't know which component of it. Is it the metabolic component? Is it the microbiome in patients who have metabolic disturbances? Is it the two of them together? Visceral adiposity, intra-abdominal adiposity, or visceral fat, and some of those aspects. But I think we agree that those patients represent a unique subset where their metabolic process is contributing to the inflammatory process. And so we're seeing an importance being placed on not only treating the IBD, but also recognizing and treating the metabolic conditions that go with them so that we can target it from both sides, especially with evolutions and how we are treating metabolic conditions and obesity going forward.
It's interesting because as an IBD specialist, we've always observed that these are conditions of the Western world, the more societies that are actually more industrialized. But then as the other parts of the world become more quote unquote westernized or industrialized, they start getting Western diseases. And the other thing is that we always would tell these doctors we tour these countries, say, well, you have it easy because when IBD first comes out, it's so easy to treat. I mean, when we had our first FDA-approved drug for Crohn's disease, infliximab, everyone got better. Yep. It seemed that everyone got better. Everyone didn't get better. But still, it was so easy. My job was so easy back then. But now it's harder and harder. And I wonder if it's part of this is the whole idea that you just brought up, this whole that the metabolic diseases, and Andres also mentioned too, the increase in adiposity and TNF production by the fat tissue, that perhaps that is why the patients become more refractory to our therapies the longer they're in this Western, either the diet or the microbiome or a combination.
Yeah, I fully agree. I think there's something going on in terms of the epidemiological factors that might be influencing it and the environmental components that probably trigger it.
Yeah, and one of our participants brought up a good point that by far, the most dangerous medicine we have are steroids, but also thinking about the impact upon metabolic conditions and diabetes, and then that, virtually all of our FDA-approved therapies for moderate severe Crohn's disease, moderate severe ulcerative colitis have been shown to decrease steroid needs, that it gives us more of a reason to get these patients onto therapy sooner because we can then, and keep them on them, so we can then perhaps prevent problems going downstream.
Yeah, and the weight gain from prednisone and steroids is quite unique. And the weight loss is not easy. And you have a lot of patients who have trouble with it afterwards. And there is a need to understand whether there's a metabolic resetting that's occurring when we give chronic prednisone and chronic steroids, because you're dealing with so many hormones and such of a huge metabolic process, and how that influences effectiveness of our drugs. Yeah.
Moving to the next topic, we had a really great lecture this morning about extraintestinal manifestations in IBD. So as an IBD-ologist, what do you do when you see someone coming into your office with Crohn's disease or ulcerative colitis and an extraintestinal manifestation? What does that mean to you as far as their disease risk and course and your therapies?
Yeah, so I think the first thing that I do is I make sure that I ask a very detailed history about possible extraintestinal manifestations. Our patients are often so debilitated by their GI symptoms that they forget the lower back pain they have every morning for 30 minutes that gets better when they're walking around, right? Or they forget the episode of really painful red eye that they had 2 weeks ago, or that rash that popped up that went away because they're too busy dealing with the colitis. And so I think that detailed history will make sure that you capture those patients. I think the second thing I do once I've identified a patient who may have an extraintestinal manifestation is to really drill down onto the localization of that, right? You'll have skin, you'll have other things, but with joints in particular and complaints of muscle aches or joint aches, it becomes really important to make sure you understand what the source of that is, because depending on what the source of that pain is or that discomfort or manifestation is, it will influence your treatments. Certain concomitant, immune-mediated disorders of the musculoskeletal system have their own therapies that also happen to work well for IBD, or they may just be manifestations of systemic inflammation that will go away once the bowel's healed. That does influence treatment selection and how you think about using your treatments for a lot of those patients.
I think we were able to take advantage of the fact that many of our therapies were first approved in psoriasis, psoriatic arthritis, or the rheumatoid diseases, and often would say to the patient, good news, we don't have this approved yet for Crohn's and colitis, but we do have it approved for your other conditions, so we can give it to you or have your specialist in your field give it to you too. So then you would preferentially choose an agent that might work for, let's say, their Crohn's and their psoriatic arthritis over one that would only work for one or the other.
Correct. Yeah. If you have two separate conditions, you preferentially choose something that works for both. like IL-23 therapies for psoriasis and IBD, anti-TNF therapy for ankylosing spondylitis and IBD, and because you'll know with more confidence that you can address both situations, and you make it a little bit easier to manage both together.
Now, when we're giving these therapies, we also realize that there's additional research in areas that are not yet approved. So one of the areas, again, it was discussed yesterday and this morning, was pyoderma gangrenosum, which can be quite troublesome. As you know, we typically give steroids, and then back in my day, we would give cyclosporin or tacrolimus and the anti-TNFs. But there seem to be some other investigations and other pathways for this condition.
Yeah, I think, we don't know that much about pyoderma. We haven't studied it the way that, we've studied other conditions. So I don't think we really have a great understanding of its molecular underpinnings. But you're right. Historically, cyclosporin, infliximab, then we'd see case reports of IL-23 therapies and some of these other agents, and even things as simple as, intralesional methotrexate injections for patients who are on sub-Q methotrexate as combination therapy. Some of these other nuances of being able to manage it, or hyperbaric oxygen therapy. There's a lot of things that people have done, but we just really don't understand it that well to really push for a specific targeted therapy development program.
And are there particular therapies that are available, FDA approved, as we mentioned, for these conditions that you're very worried about for safety reasons?
I'm not very worried about any treatment for safety reasons. I think safety as it relates to medications is a combination of the inverse of disease. So disease activity and disease worsening and prednisone use are the main drivers of bad outcomes. And then some mechanism-specific potential safety considerations. But none of those would ever force me to not offer those treatments. They would just sort of guide the decision-making on an individual basis for whether it's the most appropriate for that patient. And I think we tend to allow black box warnings or some of these limitations to drive fear in a little bit, but they're all very effective. And it's also important to know that some of the safety components that have come up, like for JAK inhibitors, really haven't been seen in our patients. They were seen in other indications and other populations, but in our long-term safety data, we're not seeing those same risks play out.
I think that's a very important point that you bring up, how safe these therapies are, especially compared to steroids, the importance of keeping people on therapy, even when they're well, for the long term. It's ironic that the American College of Gastroenterology guidelines for Crohn's disease and ulcerative colitis just came out simultaneous with this meeting. And it's quite a thick read, but I would say that one of the underlying messages is get people on effective therapy early. If they're on steroids, get them off steroids, and then continue them on therapy and monitor them appropriately.
Yeah, and I fully agree with those statements.
Terrific. Well, so this sums up our podcast from the GI Health Foundation's program. We are very happy that you were able to join us today. On behalf of my co-faculty member, Parambir Dulai of Northwestern, I'm Dr. Russell Cohen at the University of Chicago, and thank you for joining us.
Awesome. Thank you for joining us.